So we have two sections to cover today: labor and birth process and the nursing management during labor and birth. And I'll take a break between the two sections so that everybody can kind of get up, stretch, get some coffee, refuel. This section, the labor and birth process, is covered in chapter 13 of your Ricci textbook. And as Dr. Brown mentioned, it does start on page 419. So if you wanted to earmark any pages or follow along within your text, you could do that as well. Let's see. Oh, I don't know why my slide doesn't advance with my mouse. All right, well, we'll just do it this way. So what is labor? Labor is the physiologic event involving a sequential and integrated set of changes within that myometrium and cervix that occurs gradually over time in order to expel the fetus from the uterus. There are several conditions that we know to be present whenever labor begins, but we really aren't exactly certain what triggers the labor process. What we do know is that the distension of the uterus causes irritability and contractility. There are changes in the hormones estrogen and progesterone, which have been supporting that pregnancy. Estrogen increases where progesterone decreases. The number of oxytocin receptors in the uterus also increases, so that allows increased sensitivity to oxytocin. Oxytocin is a hormone released by the pituitary gland. It's naturally released by the mother, but we do have a synthetic version that we're able to provide in the hospital to help induce or augment a woman's labor. Oxytocin aids in stimulating prostaglandin synthesis. This process leads to additional contractions, woohoo, and cervical softening, progressing to cervical dilation. And we'll talk more about the softening and the dilation of the cervix. In this video here on this slide that you're about to see, it shows a woman using what we lovingly refer to as the baby dance to help encourage her labor along. So it's kind of a fun video to show that not every woman labors the same. That's kind of fun, just showing that, you know, labor is what the woman wants it to be, and her experience is unique to her and her preferences. And we'll talk more about that as well as we continue with today's lecture. I don't know why it's not going. There we go. So before the onset of labor, the pregnant woman's body undergoes several changes in preparation for the birth of the newborn. The changes that usually occur often lead to characteristic signs and symptoms that suggest that labor is near or approaching. So we have cervical changes, which refer to the cervical softening and possible dilation with the descent of the presenting part into the pelvis. It can happen from weeks to hours before labor starts. These changes occur secondary to the effects of prostaglandins and pressure from the Braxton Hicks contractions that we were talking about when Ms. Concepcion was talking about those Braxton Hicks contractions and how they're really just kind of more of an annoyance and practice run. Ripening and softening of the cervix are essential for effacement and dilation to occur. So you can't start dilating until that cervix starts effacing or getting thinner first. Lightening is when the fetal presenting part begins to descend into the true pelvis. The uterus lowers and moves into a more anterior position. When this occurs, women usually notices that her breathing is much easier. She'll oftentimes say, wow, I definitely slept much better last night. I didn't have to sit up while I was sleeping, to just kind of take that load off of the diaphragm. It also can help to decrease her gastric reflux, which is a common complaint in pregnancy. So a tip to help you remember this is think of it as lightening the load. So, they have this enormous pressure, and then all of a sudden they have this lightening that occurs, and it's that moving down into the pelvis, and it takes all that pressure off the lungs, makes it a little bit easier to breathe. We have an increased energy level, or what is also known as nesting. Women have this extra stored up energy toward preparing for the baby to come home. She can do things like cleaning the house, cooking dinners, preparing the nursery, and spending time with other children. She just all of a sudden is just very focused on preparing for this baby. Usually occurs 24 to 48 hours before labor begins, but I'm cautious with that because it's not really a scientific, we can't say that once she starts this nesting ritual that she'll have this baby within 24 to 48 hours. She can have some bloody show. The mucus plug that it initially blocked that entrance of the cervix has now loosened with the softening of the cervix and those Braxton Hicks contractions. The pressure of the presenting part also helps to release it. When it's expelled, it causes small capillaries to rupture and bleed from that cervix. Remember, we said that it's very vascular and it's friable. So anything that any movement within that cervix can cause those to rupture, and you might see some pink tinged discharge on some toilet tissue. That usually alarms the patient, and you might see them either in the hospital for evaluation, or they will call their physician to see if it's labor. Sometimes, as Ms. Concepcion can probably attest to as well, is that, oftentimes they'll bring me their mucus plug.
We've got plenty of times where we've had patients bring mucus plugs into the triage room in a tissue and be like, this is what came out of me.
Yes, if you're ever questioning if we need to see that, the answer is no.
We don't need to.
So then we have the Braxton Hicks contractions. Like we talked about, these are the practice run contractions that occur primarily in the abdomen and groin and gradually spread downward before they relax. They're usually about 30 seconds in length. They're very short. They feel like stretching or tightening of the abdomen. Many women report feeling like the baby is balling up. They'll tell you, oh, he's balling up. Well, it's not really uncomfortable, but they're feeling that tightening. They typically don't hurt. They're typically just more annoying than anything else, like we were talking about. A lot of women, once they find out that they've had these Braxton Hicks contractions and it's not true labor contractions, the next question is, well, how do I make them stop? They don't want to continue to have these Braxton Hicks contractions. They can be undetectable to uncomfortable. It depends on the woman. Remember, pain is what she says it is. Discomfort is the same thing. It's what she says it is. So what might be undetectable to one person might be a little bit more on the uncomfortable side for another. Then you have the spontaneous rupture of membranes. This is also known in the public as water breaking. They'll tell you my water broke, or it's a loss of amniotic fluid. It can occur prior to the onset of labor. So that means that you can have ruptured membranes before labor starts. It usually requires the patient to go to the hospital, and she'll go into labor spontaneously, usually within 24 hours. Many providers, though, will augment that labor, meaning they'll intervene and help to start those contractions if the labor really hasn't started within 12 hours. We're kind of on a time clock once those membranes rupture, to help reduce her risk of infection and the baby's risk of infection as well. Remember that the membranes are a protective barrier, and now without that mucus plug, we have an open highway for infection. The difference is between true and false labor. So this is everything that the patients are highly educated on, or we hope they're highly educated on in the office. That way they know when to report to the hospital or when to call their physician. This is also located in table 13.1 on your slide on page 4 and on page 424 in your textbook. So this is also available to you after lecture is complete. It's important to understand that labor occurs on a continuum, which can cause the most frustrating aspect of labor, and that's that false labor. A woman in false labor may experience contractions that can be quite uncomfortable and trigger her to come to the hospital. The contractions in some cases can even be strong and fairly regular, but upon examination, the cervix does not show significant change. So true labor, this is important, true labor is marked by contractions that become longer, stronger, and occur more frequently, with cervical dilation and effacement being the benchmark. So you have to have those longer, stronger, closer together contractions to help move that cervix. We want there to be cervical dilation. We need to see that cervix changing before we can say she's indeed in labor. So women often have anxiety about coming to the hospital and being sent home if it's not true labor. I'll say that some women do and some women don't. It depends. Sometimes we can triage the same person multiple times in a shift. They're not afraid to come in. But sometimes they're apprehensive to, come in and it not be labor, especially if it's in the middle of the night and maybe their partner isn't so keen on continuing to come to the hospital. So we want to do our best effort to really make her feel comfortable and reinforce the fact that coming in is always a good idea. We always tell them it's better to err on the side of caution than, have it be labor and ignore those signs, especially if she had other issues in her pregnancy that required her to be in the hospital on the onset of labor. So during that triage process, when she arrives, we'll check her cervix so that we have a baseline. We have baseline information. And then if she's not, advanced dilatation, or she's not have any other obvious signs of labor, then we'll go ahead and have her walk for about an hour and then recheck her. If her cervix has changed, we can go ahead, and she's having those contractions, we can go ahead and say, we're confident that this is labor, and we'll move her to a labor room. We'll admit her for labor. So we have what we call the 5 Ps. They're the factors that affect labor. We'll get into each of these in more detail in the next few slides as we go through each and describe them. But this will be helpful to review so that you know what we're talking about as we refer to each of these. So the passageway refers to the birth canal. The passenger refers to the fetus and the placenta. The powers refer to the contractions. The position refers to the maternal position. And the physiologic response is also the maternal side of things. We also have additional 5 Ps that are more client focused. They help for planning the care of the laboring family. And these, like I said, they're client focused. We're very, we want to make sure with the philosophy of lowering the technology and increasing our hands-on support during labor is there, meaning we're not so focused on the equipment that we use, but we use high touch. We're there for her. We're her partners. That refers to her caregivers. Think of the cultural differences with this one though, and who might that support person be? In some cultures, the woman support person may actually be a female relative or a group of females and not necessarily the father of the baby. So it's important to note that the cultural view of a man's involvement in the labor process does not determine whether or not he loves his partner or his child. I'll never forget the first time that I encountered this, where the father of the baby was standing outside the labor room, and I thought, I can't believe he doesn't want to be there for this. How awful. And I was quickly schooled on some cultural competence. So from that point on, I've made it a point to be very culturally sensitive and culturally aware. But it's very important that we don't just assume that the partner is the father of the baby or that the support person is the father of the baby. We need to have patience with natural timing of labor, not to rush things along, although some patients would prefer that we do. The patient's preparation refers to her own childbirth knowledge. Did she attend any childbirth preparation classes? Does she have prior labor and birth experience that she can draw upon to guide her through this current labor experience? And pain management refers to comfort measures that we use throughout the labor and birth process. This includes both pharmacologic and non-pharmacologic interventions, which we'll talk about more in depth as well. Am I going too fast?
No.
So we
No,
have
you're going good.
I'm sorry?
You're going okay.
You're
Okay.
going good, yeah.
So we have our first P, that's our passageway. The passageway is the birth route through which the fetus must travel to be born. Makes sense, right? It consists of the maternal pelvis and soft tissue. The maternal bony pelvis is more important because it's relatively unyielding. It's not going to give. During pregnancy, the hormones relaxin and estrogen cause the connective tissues to become more relaxed and elastic and cause the joints to become more flexible to prepare the mother's pelvis for birth. So this is also the hormone that can cause a little bit of unsteadiness on her feet. So, you know, she had her center of gravity is off, but then she has relaxation through her body, and it kind of makes her a little bit more unsteady on her feet. What might we be worried about? Use your chat feature. What might we be worried about with patients and all this built up relaxin and an offset center of balance?
Falls. The consensus seems to be that the patient's at fall risk.
Exactly. So we're really worried about her falling. In fact, if a patient does fall, she comes in and she's monitored for an extended period of time, usually 4 to 6 hours, just to make sure that the baby's doing okay, she's doing okay. So it is very important that we educate her on this relaxin and also how to help prevent falls, wearing sensible shoes, moving slowly between positions, those sorts of things. We have the bony pelvis. So there's true and false portions of the bony pelvis. So the false pelvis is composed of the upper flared parts of the two iliac bones with their concavities and the wings at the base of the sacrum. The true pelvis is the bony passageway through which the fetus must travel. It's made of 3 planes. So you have the inlet, the mid pelvis or the cavity, and the outlet. The pelvic inlet allows entrance to the true pelvis. So it's the first part that the baby of that bony pelvis that the baby navigates truly. It's bound by the sacral prominence in the back and the ilium on the sides. The superior aspect of the symphysis pubis in the front as well. The mid pelvis occupies the space between the inlet and the outlet. So this is a snug, curved space the fetus must travel through. As the fetus passes through this small area, its chest is compressed. This causes all that fluid and mucus that's been building up in the lungs to be expelled. This in particularly plays a very important role in the newborn's respiratory effort immediately following birth. For example, a precipitous or rapid delivery reduces both the compression time and the amount of fluid and mucus expelled from the lungs. So as you can imagine, if we have increased fluid and mucus in the lungs at the time of delivery, that baby might have a little bit more of a little harder time to go ahead and clear those lungs and breathe and have clear lung sounds. So that's more of the transition of the newborn that we'll cover later, but I just wanted you to be able to pull it together. The pelvic outlet is bound by the ischial tuberosities. It's the lower rim of the symphysis pubis and the tip of the coccyx. It's wider from the front to the back, and the outlet must be large enough to ensure the fetus can pass through. Then we have different pelvic shapes. There's 4 main shapes, and they help determine the success of a vaginal birth. So we have gynecoid, anthropoid, android, and platypoid. If you take a look at the picture on the right side of the slide and use your chat, go ahead and guess which of these pelvic shapes would be most conducive or most favorable for a vaginal birth.
Everyone's saying about C, so gynecoid or anthropoid.
So those two are gynecoid would be our number one.
Mm-hmm.
Your anthropoid, I would give you credit for because that's our runner up as far as favorability related to vaginal birth. So I'm going to give you a few tips to remember these. They're how I remember them. Remember, guys, I like to try and make things easier for you to remember, not just for your exams, but for your practice as well. If it doesn't work for you, no worries. We'll move on. If it does work for you, just go ahead and jot it down, make note of it. And that way it might make it a little bit easier in your studying. And also if you choose to go into OB, which near and dear to all of our hearts, but you might be able to use it in practice as well. So the gynecoid pelvis is the true female pelvis. It's a way, the way that I remember this is that the prefix G-Y-N-E or gyne specifically refers to women. So that might be an easier way for you to remember that gynecoid is really that more favorable pelvis. It occurs in about 40% of all women. And then vaginal birth is most favorable with this type of pelvis due to the round inlet and the roomy outlet. So it's perfect little highway for babies to travel through. Your anthropoid pelvis, which was our runner-up for vaginal birth, remember, it's the most common pelvis in men and non-Caucasian women. It occurs in about 25% of women, and its inlet is oval and the sacrum is long. So again, it's favorable for vaginal birth, but probably not as favorable as that gynecoid. Your android pelvis is more male-shaped. So this is just one crazy way that I remember it. And if you even remember just the conversation about it, maybe it'll help you. So if you Googled the Android logo, you'll see that it looks like a male robot, and that's might help you remember that it's a male-shaped pelvis, male robot, Android. It's characterized by a funnel shape. It occurs in about 20% of women. The inlet is heart-shaped, and the posterior segments are reduced. So that just decreases that availability of that baby's head to navigate through that pelvis. The pelvis will cause a poor labor prognosis and subsequently lead to a cesarean birth. Then you have your platypoid pelvis. This is a flat pelvis or flatter in shape and size. I remember this one because it sounds like platypus, and platypuses have flat bills. So if you can remember the bill of a platypus, you might remember that the platypoid pelvis is more flat. It's least common shape of pelvic structure among both men and women. The incidence is around 3%, really. The cavity is shallow, but it widens at that pelvic outlet. It makes it hard for the fetus to descend. So that's why it causes more of that poor labor prognosis with arrested descent in the inlet. It's really not favorable for a vaginal birth. So hopefully you'll be able to remember them a little bit easier with some of those tips and tricks. The soft tissue consists of the cervix, the pelvic floor muscles, and the vagina. Effacement is the thinning of the cervix. It allows the presenting part to descend into the vagina. Remember, we have to have that effacement before we have any dilation to occur. So I want to show you a quick video demonstrating the difference between Braxton Hicks contractions, true labor contractions that cause cervical change, and cervical effacement and cervical dilation. You'll see in the video, the woman uses a balloon with a ping pong ball inside to help demonstrate these differences in labor. The balloon is the uterus. So remember, the balloon is signifying the uterus. The neck of the balloon, or the part that you tie the knot to seal the air inside, represents the cervix. The ping pong ball inside the balloon represents the baby. I do want to make one note at the end of the video. The ping pong ball is birthed, but that is not how easy babies are birthed. So, so let me see if I can go ahead and share my screen. I did practice a little bit so that it would be a little bit easier for us. All right, let's see if this works.
Just squeeze the side of the balloon.
These are
like
Braxton
this.
Hicks.
Not much is happening to the neck of the balloon here, and it's not open, very much. These are the Braxton Hicks contractions that are just practice contractions that are more and more common towards the end of pregnancy, but they don't do all that much to what's happening to the cervix. So real contractions happen at the top of the uterus. That's where the power of contractions happens. It's the muscle fibers at the top here getting shorter and thicker, which squeeze the top and then pull up on the side of the uterus here. And just like with real contractions, I have everybody just squeeze and then let go, and then just squeeze and let go. You just have to do a little bit at a time. And you can see how we're getting that effacement or thinning of the cervix down here, and not much dilation is happening while we're still working on shortening the cervix here. And this is a lot of the work that's going on in early labor. It's mostly about that shortening and less about the dilation. So once we get to much more effaced, much more thin, then we're going to start dilating the cervix there. And a lot of people get kind of nervous at this point. It's like, oh no, I don't want to push. So we always have a bit of a joke. It's just like actual labor, where you'd be like, it's okay, just breathe, do it gently. You're stretching beautifully, and then just give it one more push, and the baby will be here. There you go.
So as you can see, not as easy as birthing babies. Birthing babies is not as easy as birthing a ping pong ball, but it gives a good demonstration of those contractions, that cervical effacement, the cervical dilation that occurs. Let's see if I can get back to my screen here. Woo! Miss Concepcion, you'd be so proud of me. I did it.
Very good. I'm always proud of you.
So the next P that we have is our passenger. All the factors related to the passenger are important because they have an impact on the ultimate outcome of the birthing process. The passenger includes both the fetus and the placenta. So then we have the different parts of the passenger. We have the fetus, the fetal head, the fetal attitude, fetal lie, fetal presentation. These are all listed on your slide too, so please don't panic if you think I'm going too fast. We're going to go into each of these in more detail in a moment. Fetal position, fetal station, fetal engagement, and those cardinal movements of labor. So the fetal head is the largest fetal structure. There's a variation in size and diameter of the fetal skull among all babies. The fetal head is large in proportion to the rest of the body. The bones that make up the cranium are not fused. So they're soft and pliable with gaps between the plates of the bone. These gaps are called sutures. The intersection of those sutures are called fontanelles. You'll see this in the top right here, the top picture of your slide. So you can see, I don't know if you can see my cursor, but you can see that these gaps right here are the sutures, and here is a fontanelle. This is the intersection of the gaps or the sutures. The sutures are important because they allow the cranial bones to overlap in order for the head to adjust in shape or elongate when the pressure is exerted on it by the uterine contractions or the maternal bony pelvis. So the head is very forgiving during the birthing process. Molding is the changed or elongated shape of the fetal skull at birth as a result of those overlapping cranial bones. Your fetal attitude refers to the posturing or the flexion or extension of the joints and the relationship of the fetal parts to one another. So the most common and most favorable for vaginal delivery is when all the joints are flexed. So you can see that here. This is a really good picture right here on the bottom portion of your slide, the bottom left portion. You'll see fetal attitude here as we go ahead and describe it. The fetal back is rounded. The chin is tucked on the chest here. The thighs are flexed on the abdomen, and the legs are flexed to the knees. So it's really that, fetal position. The fetal lie is the relationship of the long axis, the spine of the fetus, to the long axis or spine of the mother. It's referred to as longitudinal, transverse, and oblique. So longitudinal is the maternal and fetal spines are parallel to one another. That's what we really want to see. They're nice and parallel. Transverse is when the long axis of the fetus is perpendicular to the long axis of the mother. So their spines are perpendicular to one another, making more of like a T shape. Not a favorable lie for vaginal delivery. An oblique is when the long axis of the fetus is at an angle to the bony inlet. The oblique lie is usually when the baby's in transition to another lie. Fetal presentation, that refers to the body part of the fetus that enters the pelvic inlet first. This is the fetal part that lies over the inlet of the pelvis or the cervical os or the cervical opening. So you might hear cervical os, it's the same as cervical opening. We must know which part is coming first at birth in order to plan and initiate appropriate interventions. So we need to know up here with this lovely little baby here who's trying to show us his buttocks first, we need to know if that's a rear end or a head. And we need to know that before we progress through the labor phase. The three main presentations are cephalic or head first, breech or pelvis first, as you see here in this picture on your slide, or shoulder or the scapula first. Your fetal position describes the relationship of a given point on the presenting part of the fetus to a designated point of the maternal pelvis. The landmark fetal parts are the occipital bone, which would indicate a vertex presentation or position. The chin or the mentum would be a face position, and the buttocks or the sacrum would be a breech position. Fetal station refers to the relationship of the presenting part to the level of the maternal pelvic ischial spines. So fetal station, which I'm hoping that you guys will be able to see it, it's really kind of depicted nicely here on this, again, this bottom left picture on your slide. Fetal station is measured in centimeters and referred to as minus or plus, depending on the location, above or below those ischial spines. So here are your ischial spines. Right here you can see 0 station, okay? That's what we're referring to. The ischial spines are the most narrow part of the pelvis. Also, you can visualize that here. I don't know where my mouse keeps going. Sorry, guys. You can visualize that here where you can see that the distance between these is quite different than the distance between here. There are natural measuring point for the birth progress. So this is what we use as examiners to be able to identify what station the baby is at while we're doing our vaginal exam. So I want you to just take a peek at this slide and see that 0 station, again, is level with those bony prominences or the ischial spines. And then as we move up here, look, we have -1 or -1. -2, that's where this baby's at. This baby's at -2 station, -3, and -4. So we're moving away from those ischial spines. As we move closer to birth, we go into the positive numbers. So we have a +1 station, a +2 station, a +3 station. Oh my goodness, I messed it up. Don't be proud of me, Mrs. Concepcion. And a +4 and a +4 station. So this is a really great picture. Sometimes it's a little bit harder to recognize that we're moving in negative numbers, but if you think of it on a number line, it might make a little bit more sense. So really, when we're saying that the baby's at a -4, that baby's really just very high up, not engaged, more ballotable, and we'll talk about that too. I think Mrs. Concepcion discussed ballotment in her lecture as well. So just really good to refer to. Fetal engagement is determined by pelvic exam, like we were just discussing with fetal station as well. It signifies the entrance of the largest diameter of the fetal presenting part into the smallest diameter of that maternal pelvis. So your baby's said to be engaged when the presenting part reaches 0 station or level with those ischial spines. Again, right here, these bony prominences, 0 station, that would be engagement. Cardinal movements of labor. So this one might be a little bit harder. Bear with me as I go through and describe the cardinal movements, but I do have a video to show you, so you might be able, if you're a visual learner, you might be able to tie it together for your studying and knowledge base. So cardinal movements of labor refers to many positional changes of the fetus as it travels through the passageway. They are deliberate, specific, and very precise movements that allow the smallest diameter of the fetal head to pass through a corresponding diameter of the mother's pelvic structure. So you'll start with engagement. Again, that's when the baby's head or the presenting part is at zero station, level with those ischial spines. The descent is the downward movement of the fetus. It occurs intermittently with contractions, meaning when the contraction occurs, it moves that baby downward. When the contraction lets up, we'll have a little bit more of that upward motion, and it's a kind of a 2-step forward, 1-step back kind of game that we play until the baby is really low in that pelvis. Flexion is the movement of the fetal chin. Remember, we were talking about the position, and the chin is really tucked onto that chest. It creates the smallest false fetal skull diameter in relation to the maternal pelvis. So that baby's really trying to help mama out here, really trying to reduce that diameter for her and for him, because we know that that baby's head is definitely going to change in some shape and diameter. And then we have internal rotation is when the fetus rotates to align with the maternal long axis to accommodate the pelvis. The extension is when the head extends under that symphysis pubis. So the baby's kind of just, if you could see me, I'm doing a motion. It almost like seems like a turtle almost. The baby's trying to kind of navigate underneath. And then we have external rotation. That's restitution. It happens after the baby's head is delivered. The release of the resistance allows for the head to rotate back to its original left or right position. It's very interesting to watch. The expulsion is the actual delivery of the head and shoulders, and the rest of the body is delivered right thereafter. So I have this YouTube video. It has really obnoxious music, so for everybody's sake, I'm gonna kind of mute it, and you can just kind of pay attention to the video and the movements of this baby. Let's see. Ooh, I'm doing it. All right. So,
Good job.
Thanks, guys. So here are some cardinal movements for you so that you can see what we were just discussing. Here's that cool feature of external rotation, like a corkscrew.
Baby's turning her face.
See how it aligned with the midline of the baby's body. And baby's born. So here's a different view. It kind of puts it all together. And here's that external rotation or restitution, back in line with the baby's body. And delivery of the rest of the body. All right. Oh, shoot. Okay, let's see if I can do this.
You can.
I got this. Maybe.
There you
Great. Sorry, guys, this is a learning curve for me. I know it's a learning curve for everybody. So we're just going to celebrate the small victories. So with the next slide, we talk about powers. And remember, we talked about how the power really refers to those uterine contractions. The power is broken down to primary and secondary powers. Your primary powers are the uterine contractions, like we just talked about, but your secondary powers refer to the voluntary pushing efforts from the woman to increase that intra-abdominal pressure. So you have the involuntary, which are your contractions, and the voluntary, which is the pushing efforts from the mom. Uterine contractions cannot be controlled. Like we said, they're involuntary. So we can't ask a mom, well, just stop contracting. Can't do that. It's like blinking and breathing. It's just involuntary. They're rhythmic and intermittent with a period of relaxation between them, thank goodness, because when they come too close together, that really tuckers our moms out, and it really tuckers our babies out. So we want that. We want there to be a period of relaxation between. The pause or relaxation helps the uterine muscle to rest and restores blood flow to the uterus and the placenta, and that's really important to reperfuse the placenta and bring that oxygen nutrient back to the baby. Uterine contractions are responsible for thinning, which is effacement, so thinning or effacing, and dilating the cervix. It also thrusts that presenting part toward the lower uterine segment. Early labor contractions are usually mild. They usually last about 30 seconds, and they occur about every 5 to 7 minutes. As labor progresses, contractions become more moderate to severe, lasting longer, more like 60 seconds. And they occur more frequently, like every 2 to 3 minutes apart. When we assess the contractions, we monitor the frequency, the duration, and the intensity. The frequency is how often they occur. So we measure these from the start of one contraction to the start of the next contraction. That would be your frequency. Your duration is how long they last. So the start and stop of a contraction. The intensity is how strong they are. So just remember in here, we're going to talk about external and internal monitors very briefly, but just remember that intensity can be either subjective or objective. So it's either how strong the mom perceives these contractions to be, or how firm we assess the abdomen to be contracted, or what the internal monitors are telling us the pressure is within the uterus. So it depends on the evaluation method when we talk about intensity. Pushing, or the secondary powers that we discussed, increase that intra-abdominal pressure by voluntary muscle contraction. So she bears down during a contraction and coordinates her pushing so that she can optimize the force used to expel the fetus and the membranes. So we have mom working very harmoniously with her body. So when the contraction starts, that's when we're going to ask her to push. Pushing between contractions would tucker her out and be less effective. The position. So positioning for normal labor and birth has evolved tremendously. It's interesting because in history, we have these depictions of women who, were shown sitting upright with their hips flexed, squatting, standing, kneeling during childbirth. All these positions help to maintain flexion at that hip joint and somewhat straighten that pelvis. It's interesting because in the past 250 years, the dorsal and dorsal lithotomy positions evolved to be the position of choice by Western medicine. And as childbirth became more medicalized, it reduced the laboring woman's opportunity to just allow her to spontaneously position herself into a position of her choice, and really kind of left them just in the recumbent position. Only recently, the maternal positioning during labor has been the subject of well-controlled research. We're so fortunate that there's definitely task force and statewide research that is really supporting and educating laboring women and the nurses taking care, and physicians, everybody in the multidisciplinary team on the benefits of these different changes, and really kind of sharing the evidence that it's not beneficial to have non-moving back-lying positions during labor. They're not healthy, and they definitely have been shown to contribute to the incidence of C-section. A recent randomized control study trialed the use of a peanut-shaped ball, my favorite, during labor, and found, yours too?
Yep, my favorite.
And found that it helped to decrease the length of the labor and increase the rate of vaginal births. Great, right?
Yes, it does.
It totally does. It was associated with a significantly lower incidence of C-section. Imagine that. It's been shown to potentially improve nursing interventions to help progress labor and support vaginal birth for women laboring under epidural analgesia. Personally, in my practice, as Mrs. Concepcion and I just shared, the peanut ball is used very regularly with frequent position changes, and it helps move that labor along. Anecdotally, I'm going to toot my own horn here. In the past year, my spontaneous labors have not been to the OR for an unscheduled C-section. We've been able to, as I refer to, I get my baby before the end of the shift because I use those peanut balls, and I position my mom routinely. I let them know at the beginning to set those expectations that I'm going to be coming in about every 30 minutes and we're going to be moving. And even if you don't want to move, you can tell me, okay, 5 more minutes. I'll leave and we'll come back. But at 5 minutes, I'm moving you. I'm very firm in this because if I just allow her to kind of lay like a pancake in the bed, we're not going to get our baby and we may end up in the OR. And I just don't prefer to go to the OR. So I'm going to get my baby vaginally. And that's just that. And the women are usually very thankful that you're being active and you're hands-on. Again, reducing that technology and increasing the high touch. They know that you're present. They know you're rooting for them. So the peanut ball's phenomenal tool.
I know, I just want to chime in a minute. The peanut ball is actually shaped like, it's like a yellow peanut. It's like kind of has fat ends at the ends and then kind of more narrow in the middle. It's actually shaped like a peanut. We could sometimes call it Mr. Peanut. And, you know, we cover it with a sheet or a blanket or a chuck so that we put it in between the mom's legs and in different positions. And it has ultimately been a lifesaver for our C-section rates. It really has. It really has helped moms get in a much more anatomically and a position that helps the pelvis be able to be in its perfect alignment for that baby to have as much room as the pelvis is going to allow it to have. And we've been able to really increase our vaginal deliveries a lot since the installation of using the peanut ball on a regular basis. So yes, it's a great thing.
100%. And it's really taken off. A lot of nurses have adopted it into their personal practices, you know, as it becomes, you know, shown. I can go through a labor and a delivery and start my next labor. And there might be another nurse who doesn't utilize these options for her patient. And she just sits on that patient strip all day long. And that to me is more tiring than, you know, the celebration of having a baby. So definitely taking on a lot of fan base. The use of upright or lateral position compared to supine or lithotomy position has been shown to utilize gravity. So it helps move that fetus downward and reduces the length of the first stage of labor. The duration of the second stage, so it helps to reduce that as well, and the number of assisted deliveries or episiotomies or perineal tears. So why not use gravity? Sounds great. It promotes fewer abnormal fetal heart rate patterns. It increases comfort. So we typically see a reduced request for pain medication. It enhances a sense of control for the mother. And it also alters the shape and size of the pelvis. So it helps with that descent of the fetus. The psychological response. So it's our next P is, again, the psychological response. Childbirth can be one of the most life-altering experiences for a woman. I know that, I'll run into a patient in the grocery store years down the line. Side note, I can't recognize anybody by face after they've delivered. They've lost a lot of fluid, but they recognize me. So it is definitely a very imprinting experience for her in her life. It goes beyond the physiologic aspect, as it influences her self-confidence, her self-esteem, and her view of life, relationships, and children. So her state of mind or psyche throughout the entire process is critical to bring about a positive outcome for her and her family. Factors promoting a positive birth experience include clear information about the procedures. We need her to know what we're doing, when we're doing it, why we're doing it, how long it might take, and if it's going to be uncomfortable. We can't just go in guns a-blazing and just start doing things to her. She's going to lose trust in you, and obviously that's not good nursing practice. Support, or not leaving her alone, or not making her feel like she's alone in this process. I constantly tell my patients, I'm here, we're going to do this together. A sense of mastery and self-confidence. Trust in the multidisciplinary team caring for her is huge. A positive reaction to her pregnancy, and then a personal control over her own breathing. A feeling of loss of control can definitely send a woman into a tailspin during the labor and birth process. And then her preparation for the childbirth experience. So preparing mentally for childbirth is important so that women can work with rather than against the natural forces of labor. I can tell when a woman has gone to a class and really has been invested in learning about the process for her own knowledge and to support her own ideals of labor, versus a woman who comes in very unprepared. Oftentimes they end up losing control, and we have to refocus them. So sometimes it is, you're the biggest cheerleader in the room, and sometimes it is a little bit of tough love. I know that I've had to be firm, but it's what they need in the moment, and very individually based. Anxiety and fear decreases a woman's ability to cope with the discomfort of labor. So it's that fear, tension, pain cycle. Maternal catecholamines secreted in response to anxiety and fear can inhibit uterine blood flow and placental perfusion. So if we decrease those things, what might be happening to our baby? Use your chat to let our instructors know what you think happens when we inhibit uterine blood flow and placental perfusion.
Yeah, the consensus seems to be baby's vitals will drop, hypoxia, decel, stress, decrease oxygen to the baby, stress.
Correct. We're cutting off that oxygenation to the baby when the placenta fails to perfuse appropriately. So relaxation becomes important because it helps augment that natural process of labor. So you want to keep her as relaxed and calm as possible. So we have remember we said we had 5 additional Ps, and those 5 additional Ps were our client-focused factors. We have philosophy, partners, patients, prenatal education, and pain management. And that can all be summed up by how a person views labor, whether as a disease process or as a normal process, will influence where and how a mother will give birth, either in a hospital setting, a family-centered setting, some of the hospitals have a different model to be more family-centered, meaning that they don't necessarily limit the amount of visitors. They may have a different atmosphere where it seems more like her home. They really strive to not have labor in a prepackaged box, meaning everybody gets the same experience no matter what your ideals are. So they are 2 different philosophies. A birthing center, or maybe at home, depending on where she feels most comfortable birthing her baby. And with whom, meaning who's attending this delivery. It could be either a physician, a certified nurse midwife, or maybe even a lay midwife. And some of these birthing centers aren't staffed with traditional medical personnel. But above all, we know that women desire support and attentive care during labor and birth. For instance, a lot of women choose to use a doula, and a doula will mother the mother during that labor process. So it's kind of interesting because if you have a good multidisciplinary team who embraces the doula as part of that woman's birthing process, you can work harmoniously to help support the mom. The nurse can focus on educating for the procedures and preparing, and she's still an active role in the woman's birthing process, but that doula can be there when the nurse isn't. Oftentimes we have more than one patient at a time, so that means that we're not in the room continuously. That doula can be with that patient, and they are from start to finish. So that's a nice option. The birth process takes time. So that goes with our patients. We really have to just be patient with that birth process and know that it's not on anybody's time schedule other than the woman and the babies. Labor and delivery nurses would be extremely rich if we could successfully predict when that baby is coming. I know I've been asked, so it does not stop patients and their loved ones from asking. And I will say that we are asked every time, times a day. Grandma will come in and say, okay, well, I'm going to go get some lunch. Do you think the baby is going to come while I'm gone? And unless we're, very close to delivery, there's no way I can tell you if this baby's coming in the next 30 minutes. And then the more time we allow, or patience, if you will, for the women to labor naturally without interventions, the more likelihood that we would see the C-section rate be decreased. So when we start watching that clock and giving her a time frame, and more so in those unnecessary time moments, then we're helping that C-section rate climb. Basic prenatal education. So this can help the woman manage the labor process and feel in control of her own birthing experience. Learning about labor and birth allows women and couples to express their needs and preferences, enhance their confidence, and improve communication with the healthcare team. So they're learned. I need to go back to school. They're taught these techniques in these classes to help navigate the uncharted waters of labor and delivery. Because until you've had a baby, this will be your first experience in labor and delivery and the process of going through birth. Pain during labor is nearly a universal experience. Pain happens. We just mentioned all the reasons why this woman might encounter that uncomfortability of labor and the pelvic structure changing and being the baby navigating underneath that symphysis pubis, all that stretching and movement is not comfortable. I have not heard of one woman who said that was so amazing, I want to do it again 5 minutes after her birth. Those are the women who usually say, I'm never doing this again. We know it's a lie, but they don't want to do it again. It wasn't comfortable. They quickly forget and have more babies, but that's neither here nor there. So it's really important for us to control uterine discomfort without harm to the fetus or the labor process. And we want to focus on pain management during that childbirth. The challenge for care providers is to find the right combination of pain or coping management methods to keep the discomfort manageable while minimizing the negative effect on the fetus. And we don't want to interfere. We don't want to have any negative impacts or interfere with the normal physiology of labor or maternal infant bonding. We don't want to interfere with breastfeeding. And we also don't want to give her negative perception about her labor or her birth experience either. Again, we said that this stays with them. This is imprinted on them. So we don't want them, and they will revisit and review their labor multiple times while they process. So we don't want them to walk away with a negative memory. Okay, so we talked about how the labor process involves those rhythmic, involuntary, usually quite uncomfortable uterine muscle contractions that bring about effacement and dilation of the cervix and eventually the expulsion of the fetus. At term, the changes occur in the cervix that make it softer, and uterine contractions become more frequent and regular, signaling the onset of labor. During labor, mother and fetus are both make several physiologic adaptations. My mouth is getting so dry. Your maternal responses, which are also located on page 439 in your Ricci textbook, if you wanted to follow along or reference later, include numerous physiologic responses that occur to assist her to adapt to the labor process. Labor stresses several body systems. We talked about this during Mrs. Concepcion's lecture as well, which will react with numerous compensatory mechanisms. Maternal physiology responses include the increased heart rate. So we're going to increase roughly about 10 to 20 beats per minute. The cardiac output also increases to about 12 to 31% during the first stage of labor, and by 50% during the second stage. BP increases by up to 35 millimeters of mercury during uterine contractions in all labor stages. Your white blood cell count, or your WBCs, increases to 25,000 to 30,000 during the tissue trauma. Respiratory rate increases and more oxygen is consumed related to the increase in metabolism. Gastric motility and food absorption decreases, which results in the risk of nausea and vomiting with aspiration. So this is a long battle with physicians and anesthesiologists about allowing women to labor and eat. We know that the food helps feed the muscles, and we've been in a battle with them because food also increases the risk of the nausea, vomiting, and aspiration during anesthesia or that unscheduled trip to the OR would be quite dangerous for mom. So we've kind of ventured between keeping our NPO versus clear liquids versus no dietary restrictions in labor, as some hospitals have adopted across the United States, but it is strictly dependent on the hospital policies, the physicians, and the anesthesiologists. The temp rises slightly due to increased muscle activity. Muscular aches and cramps occur due to the stressed musculoskeletal system, and then the basal metabolic rate increases and blood glucose levels decrease because of the stress of labor. So that's significant with our diabetic moms. The ability to adapt to the stress of labor is influenced by her psychological and physical state. Factors that affect her coping ability include previous birth experience and those outcomes. Current pregnancy experience, was it planned, unplanned? What's her age? Is she a teenager? Maybe she's 45 years old with grown children, and now she's going through this process again. Any risk factors she may have or chronic illnesses, and then her weight gain. Cultural considerations, we talked about the values and beliefs about health status, and maybe the values and beliefs about men participating in the birthing experience. Childbirth preparation. Exercise during pregnancy to assist with that intra-abdominal pushing with that increased muscle strength. Expectations of the birthing experience, how she views it as meaningful or stressful. Anxiety level. Excessive levels will interfere with the birthing process, like we talked about. Fear of labor and loss of control. Fear may enhance that pain, and that may inhibit her progress. And then fatigue and weariness. maybe she's not up for the challenge. Maybe we get to a certain, she's been go, go, go. We get to a certain point and she just wants to throw in the towel. So the duration of labor can help impact that fatigue and weariness too. If she's going for hours and hours on end and she hasn't slept for 3 days leading up to this labor, that's going to be very important. Fetal responses. So there's several physiologic adaptations which occur to the fetus or in the fetus. The respiratory changes during labor help the fetus to prepare for extrauterine respiration immediately after birth. The fetus experiences labor along with the mother. We need to remember that the baby is the patient, the second patient that we can't touch. So we have 2 patients during this labor experience. If the fetus is healthy, the stress of the labor usually has no adverse effects. The nurse is alert to any abnormalities in the fetus's adaptation to labor. The fetal response to labor includes the periodic fetal heart rate accelerations and slight decelerations related to fetal movement, fundal pressure, and uterine contractions. Decrease in circulation and perfusion to the fetus secondary to uterine contractions. The healthy fetus is able to compensate, where maybe an unhealthy or stressed fetus loses the compensatory mechanism, and we definitely see that on our monitors. An increase in arterial carbon dioxide pressure, and then decrease in fetal breathing movements throughout labor, and decrease in fetal oxygen pressure with a decrease in partial pressure of oxygen. All right, so labor is typically divided into 4 stages. The first stage, or dilation, consists of 3 phases. So we have stages and phases. The first stage, dilation, is the strongest stage. It begins with the first true contraction and ends with the full dilation of the cervix. Since it's the longest stage, it is also divided up into 3 phases, like we just talked about. Each phase corresponds to the dilation and effacement of the cervix. So the latent phase, or early labor, begins with the start of regular contractions and ends with rapid cervical dilation. The cervical effacement, or thinning, occurs during this phase and goes from about 0% to about 40%. Cervical dilation also goes from about 0 to about 3. And then contractions occur every 5 to 10 minutes and last roughly from 30 to 45 seconds and are mild by palpation. Most women during this phase are talkative. They perceive the contractions to be similar to menstrual cramps, so they can talk, walk, even dance through them. Women can stay home during this phase and alert their provider of the start of labor. The latent phase lasts about 9 hours for nulliparous women. So nulliparous woman means a woman who's never delivered a baby before. Think of null. Null means 0. About 6 hours for multiparous women. So those are the women who have delivered at least 1 baby previously. The active phase encompasses a time from an increase in the rate of cervical dilation until the completion of cervical dilation and is characterized by the cervical dilation from 4 to 7 centimeters, cervical effacement from 40 to 80%. The active phase lasts up to 6 hours for nulliparous women, so again, first-time mamas, and 4 to 5 hours for multiparous women. So again, 6 hours for nulliparous women and 4 to 5 hours for multiparous women. The fetus descends further into that pelvis. The contractions become more frequent. They're happening about every 2 to 5 minutes now. An increase in duration lasting about 45 to 60 seconds. They typically palpate moderate to strong. The woman becomes more intense and inwardly focused. At this point, we can say that, oh, she's getting serious. When I've been joking around with a patient from admission to active phase, and then all of a sudden she's serious and doesn't want to joke with me, I know we're getting down to business. She's absorbed in the seriousness of her work and the work of her labor. And she'll use the breathing and relaxation techniques during this time. So she's really having to work through these contractions, breathing through them, whereas before she was just kind of breathing normally. Now she has to concentrate. Relax typically. She may become diaphoretic, and she may start having those feelings of loss of control. So then we have the second stage, or the expulsive stage, and it begins with the complete cervical dilation, 10 centimeters, and the complete effacement to 100%. It ends with the birth of the newborn. This stage involves moving the fetus through that birth canal and out of the body. Remember those cardinal movements of labor? Those occur during this early phase of passive descent. The contractions are strong. They occur every 2 to 3 minutes, and they last 60 to 90 seconds. The average length of the second stage is 1 hour in nulliparous women and less than 1 hour for multiparous women. The mother usually feels more in control, less irritable, less agitated. She's focused on the work of pushing. So this is where she gets really serious. She's diving in. She's saying, okay, you're right, I can do this. And she's very focused on following your direction and doing what she needs to do in order to birth her baby. So the maternal urge to push is generally felt when there is direct contact of the fetus on the pelvic floor. These are those stretch receptors that I was discussing. So the stretch receptors in the wall of the vagina, rectum, and perineum, they all communicate the pressure of the fetus descending in the birth canal and cause the mother to feel an overwhelming urge to push, along with an increased abdominal pressure with a contraction. So those are the stretch receptors that I was saying are not blocked by that epidural. If she has one in place, she will feel the urge to push regardless, or we hope she does. Most people do. Fetal head during this time is negotiating the pelvis and rotating and advancing in descent. During this stage, the perineum is bulging and there is an increase in bloody show. So we're starting to see that head come down. The fetal head becomes apparent in that vaginal opening, but disappears between contractions. Remember, we were talking about earlier, the 2 steps forward and 1 step back. So it kind of, for lack of better analogy, plays peekaboo. Like it kind of comes forward and then it might disappear behind the labia and then come forward again with the next contraction or next push. Crowning occurs when the fetal head is visible at the perineum without regressing back to the pelvis after the contraction. So when we have that baby, moving, doing the 2 steps forward, 1 step back motion, that the baby hasn't crowned until that motion stops, until the baby's head comes down and stays down with or without the contraction. The fetus rotates as it maneuvers out, like we saw in the video. And then the average time for the second stage is 3 hours for a first labor, so for your nulliparous women, and up to an hour for subsequent labors. So those would be your multiparous women. This third stage begins with the birth of the newborn. It consists of 2 phases. So you have the separation and the expulsion. The uterine contractions continue after the birth of the fetus. This causes the placenta to pull away from the uterine wall. Signs of that separation, the uterus rises upward, the cord lengthens, and then there's a sudden trickle of blood from the vagina, and the uterus changes to a more globular shape. After separation of the placenta, the woman will experience continued contractions, which cause the placenta to expel within 2 to 30 minutes. Some take longer than others, unless the physician decides that they're going to apply gentle traction to help assist it along. After the placenta is expelled, the uterus, or the fundus, is massaged briefly until it's firm so that the uterine blood vessels constrict, minimizing the possibility of hemorrhage. So we give a little fundal massage, as you can see in the bottom picture here. Maybe I can find my mouse. This bottom picture is kind of depicting, she's checking where the fundus is. And if she were to move this hand around in a massaging technique, she would be massaging the fundus of this uterus to help it contract and decrease the bleeding. The average blood loss is approximately 500 mLs for vaginal delivery and roughly 1,000 mLs for C-section. It's very important that the placenta be inspected for its intactness to make sure all the sections are present after it's been expelled. If any piece is still attached to that uterine wall, it places the woman at risk for postpartum hemorrhage. And the reason why she's at increased risk for postpartum hemorrhage is because it interferes with the ability of the uterus to contract fully and effectively. So it's also important that we get all the pieces of the placenta out, because if it were to go unnoticed, if we didn't check that placenta for intactness and we missed the fact that there was a piece left behind, it could increase the risk of bleeding and infection if that woman were to be discharged home with pieces of placenta still inside. The fourth stage, or the restorative stage, begins with delivery of the placenta and ends with the initial physiologic adjustment and stabilization of the mother. It's usually 1 to 4 hours post-birth. This stage initiates the postpartum period. So we've gone from labor and delivery to now postpartum. Mom typically feels a sense of peace and excitement. She's wide awake and very talkative. And typically she wants to let everybody know she did it. And she wants to share all of her experiences with everybody in the room. And anybody who enters, she'll start all over and tell them all about how horrible it was or how amazing she did. Or she's very, very talkative during this phase. The attachment process begins with the baby. The mother's fundus should be firm and well contracted. At this time, it's located at the midline between the umbilicus and the symphysis pubis. And then it rises to the level of the umbilicus about 1 hour after the birth. So we'll see it rise back up again. If the uterus becomes boggy, we can massage it to keep it firm. And that's, again, what she's doing, or he's doing down here in this picture. The focus during this stage is really to monitor the mom closely to prevent hemorrhage, bladder distension, and venous thrombosis. As nurses, we monitor vital signs, the amount and consistency of the vaginal discharge, the uterine fundus. Is it firm? Is it boggy? We usually monitor every 15 minutes for the first hour or more, depending on hospital policies. So each hospital or system adopts what they consider their recovery phase to be based off of our professional organization as well. So it is governed, but I feel like some people are a little bit more loose as far as what they consider that recovery phase to include. The mom will feel cramp-like discomfort. She'll often tell you, I'm still having contractions. She's cramping. That cramping is good. It signifies that that uterine muscle is contracting to help reduce her bleeding. And we just have to continue to educate her and offer her maybe like a non-opioid analgesic to help her with that discomfort. Just similar to a period, she might take some Motrin, ibuprofen. So I think that ends that lecture, and we're going to go ahead and start the next one, but we can take, you guys think like a 5-minute break would be okay, or we need more time?
I'm hearing 10, 5, 10.
Well, the next section, I only have an hour to do it, and it's quite intensive. So
Let's take a 5.
Let's take a 5.
might be better. Okay. So 5-minute break. We'll be back at 10:07.
Sandra, everything's been going pretty good on the chat. I've been answering most of the questions and keeping up with their discussions. You have any issues?
Thank you guys. No, it's so weird talking and not hearing anything.
I'm sure it is.
I had a bird fly into my bedroom window and I totally lost all train of thought.
That would do it.
Oh. All right. It's 10:07 now, so we're going to go ahead and get started back up. So welcome back. I hope you got something to fuel you through this next part of the lecture. Like I said, there is a lot of material covered between these two lectures. There's a lot of new terminology. If you don't know a word, please write it down. You can either save it for the end of the lecture where we can help define the word or the term, or you can look it up for your study material after. So if you're waiting for me to tell you the meaning of the word, then please write it down, because that means that you need to incorporate that into your study habits for this upcoming exam. Not this upcoming exam, the next exam. This section, the nursing management of labor and birth, is covered in chapter 14 of your Ricci textbook, and I don't have the start page. Dr. Brown, do you have, oh, I do, I lied.
451.
Yeah, on page 451 of your text. So if you wanted to follow along, I am also going to be referring to a couple of the diagrams in your book, so it might be helpful to have it open and next to you, just so you can earmark and visualize what I'm discussing. So we're going to talk about maternal assessment. Nurses need to be respectful, available, encouraging, supportive, and professional in dealing with all women across all cultures. That's true for all nurses. Nursing management for labor and birth involves an assessment, providing comfort measures and emotional support, providing information and instruction that is clear, that we ask for a return demonstration, or the fact that they, or repeat back so that they can demonstrate that they understand what it is you are trying to educate them on. Advocacy and support for the partner or whoever they've designated as a support person. Providing the highest quality in maternity care is dependent on nurses valuing that childbirth experience. Remember, we have to be patient and supportive. We have to respect the birth process. And we've committed to being there for that woman in that very trying and emotionally taxing time in her life. It's important for us to recognize it as a life-changing experience for women and families. And we need to provide care that protects, promotes, and supports that physiologic childbirth. Various techniques are used to assess that maternal status. They determine the woman's response and her progress in the labor. So we assess maternal vital signs, temperature, blood pressure, pulse, respirations, and her pain. We review the prenatal record to identify any risk factors. How has her pregnancy looked? Has she had any issues? We look at her lab results. We assess her cervical dilation. We do this periodically to identify the progress. At a certain point, though, especially after she's ruptured, we're going to back off on those cervical exams because we don't want to introduce any unnecessary bacteria into the birth canal. And then we're going to move our vaginal exams to when she's feeling pressure or pressure that doesn't go away. So we want to make sure that we're not unnecessarily checking. And they will ask multiple times, especially moms and grandmas in the room who will say, how dilated is she now? So it's just something that we don't need to know in order for labor to progress. But it is helpful information to help us identify and prepare, identify for any risk factors for arrested descent and so on. So we evaluate maternal pain and the effectiveness of pain management as well. The World Health Organization, or WHO, recommends digital vaginal exams at intervals of 4 hours for routine assessment and identification of delay in active labor, like we were just talking about. We need to check. We don't need to check so often. So we need to know what's happening and how labor is progressing, but we don't need to be in there all the time. The vaginal exam is an assessment skill that takes a lot of time and experience to develop. It's something that I can describe how we do the exam, and we'll do that in a minute. But until you examine a cervix for the first time on your own, it doesn't all kind of come together. I'm going to be honest. It takes a lot of practice. I know that my first vaginal exam, maybe Ms. Concepcion has her own experience, but my preceptor said, "You've got this." She was almost like my own labor coach. "You've got this. You can do this. Go check her." So I went and checked her, and I came out all excited, and she said, "Well, what is she?" And I said, "Well, she's either completely closed or completely dilated. I have no idea." So it's just, it's a skill. So I don't want to minimize or say that this is so easy. Just find the ischial spines, just find the cervix. It's something that you learn to do over time. Yeah. Vaginal exams are performed by most labor and delivery nurses in the community hospital setting. Physicians perform them in the office and during labor. Midwives or certified nurse midwives perform them as well. The only variation that I want to make mention here is that if indeed you choose to go into labor and delivery and you go to a large teaching hospital, you're going to encounter interns or you'll encounter interns, and they typically take over the vaginal exams. So the nurses in those settings, those large the large teaching hospitals, they typically don't have a really strong cervical assessment skill. They kind of lose it. You could even go into one of those teaching hospitals being strong, and if you don't use it, you will lose it. It comes back quickly, but at the same time, I don't want you to think that all labor and delivery nurses perform every exam, because it is determined by the setting and the physician. Some physicians prefer to check their own patients, but mostly done by labor and delivery nurses. The purpose of performing the exam is to assess the cervical dilation, the effacement, the membrane status. It's also helpful to gather information on fetal presentation, the position, the station, like we talked about, finding those ischial spines and figuring out if that baby is really high and palatable, or if that baby is really more of like a +2 and is coming down nicely. The degree of head flexion, and the presence of the fetal skull swelling or molding. So sometimes we can feel, it almost feels like, for lack of better terminology, it almost feels like a firmer balloon or like Play-Doh at the top of the head. You can feel it's kind of squishy. It's not hard. You can't feel that bony prominence anymore. You feel more of like a ball it almost feels like a harder balloon, I guess is the best way I can describe it. I don't know if Ms. Concepcion has a better way of describing what molding feels like.
Yeah, it's almost like the balloon kind of is odd shaped. The molding, you'll see where the head kind of just like fits the canal, fits that pelvic vaginal that vagina really well, and so you're able to see that the head almost kind of like molds into the shape of the patient's vagina and the pelvis, so that way it can kind of fit through there better. So. Mm-hmm.
So how do we perform this exam? We were talking about how I'm going to go ahead and describe to you how it's done. But again, this is definitely a skill that is worked upon. So the examiner inserts the index and middle fingers into the vaginal introitus. And you can see that here on your slide. Let me see if I can find my mouse. So index and middle fingers into this vaginal introitus. The cervix is palpated to assess dilation, effacement, and position. So posterior, interior, meaning do they have to go way back here to find the cervix, or is the cervix right here, more midline, anterior? Really kind of, especially if you have short, stubby fingers like me, really kind of utilizing really kind of utilizing this, the middle finger here I hook that no, wrong, sorry, scratch that. I hook that cervix and kind of walk it forward a little bit until I can also assess it with my index finger. If the cervix is open to any degree, we can assess the presenting fetal part, meaning I can feel, where do I point it? Here. I can feel the fetal head, maybe. Mm-hmm. I can determine the fetal position. I can determine the station. Again, sweeping my fingers side to side here and finding those ischial spines and where in relation that is to the fetal head. And the presence of molding can be assessed, like Ms. Concepcion and I were just discussing. In addition, the membranes can also be evaluated, and they can be described as intact, bulging meaning they're coming through, ooh, hello. They're kind of bulging out here, maybe again, like a squishy balloon, mm-hmm. and can kind of move past that, and I can feel the fetal head beyond it, but I know that there's a bag or a membrane right here. Or it's ruptured. Sometimes I can feel with a contraction, I can feel that surge of amniotic fluid pouring over my fingers. I can tell that she's ruptured by that sensation as well. All right, so primary power of labor is the involuntary uterine contractions. Remember, we just talked about the 5 Ps, and power was one of them. The uterine contractions increase intrauterine pressure, causing tension on the cervix. The tension leads to cervical thinning and dilation, which in turn eventually forces the fetus through the birth canal. The properties of the contractions, so we have these down here are trying to signify contractions. Mrs. Concepcion and I would both agree that these are really crappy contractions. Yeah. This is not what I want to see. But the contraction itself, so that systole phase, the relaxation right here where the contraction's coming down is the diastole phase, the building up right in here. So we're building, oh my gosh, why does my mouse keep disappearing? The building up again. So we're building up again into this next contraction is the increment. And then it reaches the acme right here, the top, the acme or the peak. And then it starts letting down again. So the decrement phase. The contraction or the contraction pattern is monitored by palpation and by electronic monitoring. So we assess the contractions based on their frequency. Remember how far apart are they? The start of one contraction to the start of the next contraction. The duration, how long is it lasting? Here. And the intensity and the resting tone. So intensity, I always educate the family that please don't say, whoa, that was a big one, because this just tells me she's having contractions. If I have a really tiny mama with a large belly, I'm going to see every little movement of that baby and the uterus. I'm going to pick up her contractions typically quite well. The external fetal monitors don't show me or tell me what the actual intensity or the actual resting tone are. I can only know that if I place internal fetal monitors and contractions as well. So contraction intensity with 30 milli initiate cervical dilation, and that's why those Braxton Hicks contractions don't do squat for my cervix. They really need to be those stronger contractions. Again, the intensity of 30 millimeters of mercury or greater to initiate that cervical dilation. During active labor, the intensity usually reaches 50 to 80 millimeters of mercury. The resting tone typically sits around 5 to 10 millimeters of mercury in an early labor and between 12 to 18 millimeters of mercury in an active labor. So we're building that pressure within the uterus. To palpate the fundus for contraction intensity, this is a trick that we're all going to try together. we place the pads of our fingers on the fundus and describe how it feels. So we have a mild contraction, and if everybody just touches their nose, that's what a mild contraction or a uterus feels like. So then if we touch the chin, that's more of a moderate contraction. We can feel some firmness. And then when we touch our forehead, that's a strong contraction. And that's typically, you know, that's pretty much what the uterus feels like when it's at that acme or the peak of the contraction. So the fetal assessment identifies well-being or signs that indicate compromise. So the fetal assessment focuses primarily on the character of the amniotic fluid and the fetal heart rate pattern. The amniotic fluid should be clear when the membranes rupture. And the rupture can either be spontaneous or artificial. Spontaneous meaning she ruptures on her own. She could be eating dinner, she could be sleeping and lying in bed, and her membranes rupture, and she has that sense of fluid releasing. Artificial refers to our interventions. What have we done to cause that membrane to rupture? So it's usually done by means of an amniotomy, like an amnio hook. And an amnio hook looks like a crochet hook. Yeah. So we hand this to the provider. This is not something that nurses do. Can happen when we're doing our vaginal exam, so it's never intentional. But it's done by the physician. We hand the hook, or we allow them to take the hook out of the package sterilely, and they insert it between their index and middle fingers, and they guide it to snag the membranes until it ruptures. Cloudy or foul smelling fluid indicates infection. So we should always, or we should want to see clear fluid. Green fluid, remember we talked about that first meconium, that first time the fetus passes meconium inside the uterus, that green fluid signifies meconium. It means that the baby has already had his or her first stool inside the uterus. They may pass this meconium prior to delivery due to transient hypoxia, prolonged pregnancy, referred to as post-dates, cord compression, intrauterine growth restriction, or IUGR, maternal hypertension, diabetes, chorioamnionitis, which is the inflammation of the membranes due to infection. Those are all things that could stress a baby, and then the baby might have their first bowel movement. So it signifies that something's happening to make this baby not quite so happy inside. A fetal heart rate pattern can be monitored intermittently for low-risk women. So this is a practice that is really kind of gaining more momentum. Again, it used to be a practice routinely used. Oh, look, Dr. Brown has you really have an amnio hook? Look at you, gold star.
There we go.
So do you see the little point on the end there? It almost looks like a bird's bill. That is actually quite sharp. It can snag a glove. And for that reason, when the physician advances it again through those two, or along those two fingers, and snags that membrane, it'll actually break the membrane. So that's an example of an amnio hook. So if everybody could just look at Dr. Brown's video, she is actually showing you what it looks like.
Yay.
Yay. Dr. Brown. That is a gold star for today. You came prepared.
There's a internal monitor too.
Oh, perfect. Hang on to that.
Okay.
Awesome. Thank you. So we were talking about intermittent fetal monitoring and how it is widely underused. We typically use continuous monitoring, which means that we have the monitors on the abdomen at all times, or internal monitors in place at all times to assess the mom. I honestly, personally believe that it's just become, as you may or may not know, maternal, fetal, and newborn nursing is a highly litigious field, and I feel like a fear factor of litigation has increased our use of maternal monitoring, and we've steered away from best practices of intermittently monitoring those low risk women. So by intermittent monitoring, I'm talking about here this middle picture where she has the Doppler on the abdomen and she listens at intervals, usually active labor about every 30 minutes. She's listening before a contraction, during the contraction, and after the contraction to listen for those changes in the fetal heart rate. So fetal heart rate monitoring is just as much a visual skill as it is an auditory skill. So I can, and I know Ms. Concepcion can probably agree too, is that when I'm laboring a woman, I can actually have my back to the fetal monitor. And during pushing, I can hear those changes in the fetal heart rate, and I can know that we have a baby that's bradycardic. And I don't have to see it to know what I'm hearing. And that's another skill that you just develop over time. So intermittent monitoring used during the pushing phase would be about every 5 minutes. So it is a tedious skill. It requires a lot of, again, hands-on care with your patient. So again, I feel like we've gotten a little bit lazy, a little bit fearful, and we've moved more to over here on the left-hand side, the left picture, we're seeing that continuous monitor hooked up to the abdomen. We have the ultrasound, which it tells me the baby's heart rate is over on the bottom here, detecting that heart rate here. And then this is the TOCO, and this tells me the contraction frequency and duration. It's really picking up those contractions. Over here, which Dr. Brown had an example of, this is the example of a fetal scalpel. So is in a sheath. So it's nice and firm. It almost looks like a straw. The end of the straw, I don't know if you can see it.
I can't, I don't know where to put it to where it's going to have a dark background.
Right there, you're good.
So I can point at it on the screen too. So down in your right-hand picture, you'll see at the top here, this top portion, it almost has like a corkscrew electrode here. And it literally screws onto, down here on the baby, on the fetal head, screws onto the scalp to help send those heart rate signals to the monitor. So we would use this if maternal habitus was increased and we couldn't hear the fetal heart rate continuously. There was some breaks in the tracing, or we had concerns that maybe what we were monitoring wasn't accurate. So we're gonna go ahead and have the physician, and in some cases, the nurses can apply these, have the physician place the fetal scalp electrode to give us a better picture of what's going on with our baby. It gives us real-time, accurate information on the heart rate. So thank you, Dr. Brown, for bringing your show and tell equipment to the lecture.
Toys are fun.
I love toys. Okay, so now we're going to get into the nitty-gritty of the fetal heart rate and the tracings that we've been referring to. So all nurses who care for women in labor need to be trained in the interpretation and documentation of fetal heart rate tracings, as well as the interventions necessary. So a lot of our nurses are actually certified in fetal heart rate tracing. So we're able to say that we are knowledge experts in the interpretation and documentation of these fetal tracings. It's a very valuable skill to have if you're going to be a labor and delivery nurse or a high-risk nurse. So there's different fetal heart rate patterns, as mentioned on the slide going down here. We have category 1, 2, and 3. Category 1 is strongly predictive of normal fetal acid-base status at the time of observation. At the time of observation is very important. So we need to make sure that we're very clear that what we're seeing on the strip is a window into what's happening intrauterine. So I cannot look at a strip at 10:31 and say that baby looks good and know for certain that at 10:35 the baby still looks good unless I'm looking at the strip for 10:35. So it is in the moment telling you what's happening. It's not typically predictive of what's going to happen or what could happen. Category 2, and that's true for all the categories, just so you know, fetal heart rate tracing is a window into the uterus, essentially. So category 2 is not predictive of abnormal fetal acid-base status, but it does require evaluation and continued monitoring. So this is the patient that you're like, category 1, she's great, everything looks good. Category 2, I'm going, looks okay, but yeah, it's not a category 1. Category 3 is predictive of abnormal fetal acid-base status at the time of observation. Remember, it's a window. We're looking at that time. We're saying this baby looks like it might have some impairment, and requires prompt evaluation and interventions. Some of those might be providing maternal oxygenation, changing the maternal position. And we do this rapidly. I always tell my patients, if I come in here and say, we need to move now, we're moving now. Any other time, I always give her the choice. Would you like to move now or in 5 minutes? But if I'm noticing that the baby's not doing well, we're moving now, no questions asked. And I've been known to move her for her. So we just start the movement process without asking.
We'll have like 50 people walk in there.
Yes.
And 50 nurses will all be like, okay, we're moving you now. And she'll be like, what the heck? And everybody's like, we grab one leg, we move her, we pull it from the other side. And that's what we have to do in order to be able to protect the baby and provide oxygen to that baby. So.
And before she knows it, she's in her next position and there's no And sometimes we have to do that 3 and 4 times, all within the same episode, because the baby might not like that next position. Mm-hmm. So we're just in there flipping, flopping, and turning until we have a happy baby. So we can also, we need to treat the maternal hypotension that may have caused this if that's present. And then we need to discontinue any labor augmentation medication. So that's all done seamlessly. So if you remember back to Mona, the big conversation was, what do I do first? The morphine or the oxygen? I know that I have to do the oxygen first. I need you to understand that all this is happening at the same time. So we're changing position, turning off the medication, providing oxygenation. Like Mrs. Concepcion just said, there's 50 people in there. We're all hands on deck, and it works harmoniously. So all of this is happening at once. The baseline fetal heart rate refers to the average fetal heart rate that occurs during a 10-minute segment. So this is the portion where I want you to go ahead and flip to 462 in your Ricci textbook, if you have that in front of you, just so that you can visualize what I'm talking about. And I'm going to be referring to the figure 14.7 in your upper left-hand corner. It gives you the different strips and examples of variability, but I want to show you that the top strip in the top section, the one that's labeled long-term variability, average or moderate. So you'll see the contraction pattern in the bottom there, but that top piece is the fetal heart rate. What we're looking for here is patterns. Where does my line typically fall throughout that 10-minute segment? I'm looking to see what the baseline fetal heart rate is. Is it 130, 135? And then I need to exclude any periodic or episodic changes, such as tachycardia or bradycardia, or any of the accelerations. So we'll get into this more. I don't want you to feel overwhelmed. I just want you to visualize. The fetal heart rate is assessed when the mother has no contractions and the fetus is not having episodic fetal heart rate changes. So again, I have to, where I had this big long strip and I said, okay, where does most of my strip fall through? Where can I say that the baseline is? Now I have to exclude any episodic changes. And then I also cannot look at the strip during a contraction to determine baseline. So I have to look at the flattened portions of the contraction monitor to say, where is my baseline when mom is not having a contraction? So then it reduces the amount of strip that I can assess for baseline, if that makes sense. So normal baseline is usually between 110 to 160 beats per minute. Quick changes above or below that are okay. We don't want to see long, prolonged variances outside of that range. We'll discuss those in a minute too. So with fetal bradycardia, the fetal heart rate is below 110 beats per minute and lasts 10 minutes or longer. So before we can call it fetal bradycardia, it has to be at the 10-minute mark or longer. Bradycardia is the initial response of a healthy fetus to asphyxia. It's caused by fetal hypoxia, prolonged maternal hypoglycemia, fetal acidosis, narcotic medication for pain management, hypothermia, epidural for pain management, maternal hypotension. So again, that's where that epidural comes in. Oftentimes after the epidural is placed, mom will have a hypotensive period and baby becomes hypotensive, shows some decreases in the fetal heart rate, prolonged umbilical cord compression, or the fetal congenital heart block. So we're seeing some cardiac anomalies here too. And let me see if I can find I don't think I can find an example on the fly. But fetal tachycardia, so moving along. Fetal tachycardia is when the fetal heart rate is greater than 160 beats per minute and lasts for 10 minutes or longer. So 10 minutes or longer for bradycardia or tachycardia. It can be an early compensatory response to asphyxia. Those causes include fetal hypoxia, maternal fever, maternal dehydration, amnionitis, drugs, maternal hyperthermia, maternal anxiety, fetal anemia, prematurity, fetal infection, chronic hypoxemia, congenital anomalies, fetal heart failure, or fetal arrhythmias. So a long list of things that can cause fetal tachycardia. Baseline variability is important. It's a clinical indicator that is predictive of fetal acid-base balance and cerebral tissue perfusion. So baseline variability is defined as irregular fluctuations in the baseline fetal heart rate. It's measured as the amplitude of the peak to the trough in beats per minute. It represents the interplay between parasympathetic and sympathetic nervous system. It has moment-to-moment changes in fetal heart rate due to the push and pull effect of both the sympathetic and parasympathetic nervous system in play. Its presence implies that both branches are working and receiving adequate oxygenation. Variability is one of the most important characteristics of the fetal heart rate. So if you go back to your 14.7 and you see that long-term variability, average to moderate, you see how the line is not just a straight line, it changes. The ups and downs, or the moment-to-moment changes in that, is what we refer to as variability. So if you move down to minimal variability, which we'll get to in a moment, and compare the two, you can see the difference in how those moment-to-moment changes have decreased. So variability is described in 4 categories. Those are the ones that we're talking about on page 462 in Ricci. So you have your absent or undetectable, your minimal, which is observed typically at less than 5 beats per minute. You have your moderate variability, which is between 6 to 25 beats per minute. And you have marked variability, which is greater than 25 beats per minute. We typically see the moderate or average, where you're seeing in the top section of variability. And that's what you want to see to signify that you have a very happy baby and is handling labor quite well. Your absent or minimal variability is caused by fetal acidemia due to your uteroplacental insufficiency. So the placenta blood flow is decreased. And again, we said that when placental blood flow decreases, it decreases the oxygen delivered to the baby. the cord compression, the preterm fetus, maternal hypotension, uterine hyperstimulation. So now we have too many contractions. So it's important to know that when the contraction occurs, it's almost like tying a rubber band around your finger. I'm sure we've all played with a rubber band at some point. When you tie that rubber band around the finger and the finger turns purple, that's the decreased tissue perfusion, decreased oxygenation to the tissue. That's the contraction. When I release the rubber band from my finger and my capillary refill occurs, my finger is turned to normal perfusion. That's that decrement or the relaxation of the uterus. It allows for the oxygenation to be delivered to the baby. So hopefully that'll be a little bit easier way for you to recognize that during that contraction, we're decreasing that oxygen flow to the baby. And then after the contraction is when that baby gets that oxygen store delivered and can start recovering from the stresses of labor. So if we have too many contractions, that's essentially leaving that rubber band around my finger and decreasing the tissue perfusion to the tip of my finger for a long period of time. We could have a placental abruption, where the placenta prematurely separates from the uterine wall. And then we could have fetal dysrhythmias. Our interventions include lateral positioning of mom, increasing her IV fluid rate, administering O2 at 8 to 10 liters via mask, considering internal fetal monitors. Remember, we said that when we really need to see what's going on, we're going to go ahead and include those internal monitors so that they can show us a better picture of what's happening. And then documenting our findings. We need to report our findings to the provider and start preparing for a possible C-section. Moderate variability indicates autonomic and central nervous system are well developed and well oxygenated. It's considered a good sign of fetal well-being. It correlates with absence of significant metabolic acidosis. Interventions aren't needed as this is what is considered normal and expected. This is good. Again, we have a happy baby. Marked variability occurs when there are more than 25 beats of fluctuation in the fetal heart rate baseline. Causes could include a cord prolapse or compression. With a cord prolapse, the cord slips through the open cervix before the baby and decreases the perfusion to the baby. So that's an emergency. We are definitely going to have a operative birth in the OR. Maternal hypotension, uterine hyperstimulation, again, that's too many contractions, decreasing the placental perfusion, and a placental abruption. Interventions, we need to determine the cause if possible. We need to move mom into a lateral position, increase IV infusion rates, observe for changes in the fetal heart rate tracing, consider internal fetal monitoring, communicate the pattern to the MD, and prepare for a C-section if there's no change. So again, these are all happening harmoniously in the room with multiple hands on deck. You are not alone. Temporary recurrent changes made in response to a stimulus. So those are our fetal accelerations and decelerations. Fetal accelerations, again, those are your page on page 462 in your Ricci. Are transient, abrupt increases in the fetal heart rate above the baseline that last less than 30 seconds from onset to peak. They're associated with parasympathetic nervous system stimulation. They're visually apparent with elevations of the fetal heart rate of more than 15 beats per minute above the baseline, lasting longer than 15 seconds, but less than 2 minutes. It's considered reassuring. It doesn't require any intervention. It denotes fetal movement and fetal well-being, and it's the basis for non-stress testing. So in non-stress testing, we check to make sure that we have fetal accelerations 15 beats per minute above the baseline by 15 seconds or more. And we have 2 of those in a 20-minute tracing to say that her tracing is reactive. Sorry, I had a moment of dyslexia. Decelerations is a transient fall in fetal heart rate caused by stimulation of the parasympathetic nervous system. They're described by their shape in association to the uterine contraction. They can be classified as early, late, or variable. Early decelerations are visually apparent. They're usually symmetrical. They rarely decrease more than 30 to 40 beats per minute below the baseline. They're characterized by a gradual decrease in the fetal heart rate in which the nadir, or the lowest point, so it's where the deceleration reaches its lowest point, occurs at the peak of the contraction. Onset, nadir, or the lowest point, and recovery of the decel occur at the same time as the onset, peak, and recovery of the contraction. They're most often seen during the active stage of any normal labor during pushing and crowning. They're caused by fetal head compression, which results in a reflex vagal response. They're not indicative of fetal distress, and they don't require any interventions. So early decelerations are okay. Variable decelerations are the most common decel pattern found in laboring women. They're apparent, abrupt decreases in the fetal heart rate below baseline with unpredictable shape on the fetal heart rate baseline. So they're not consistent. They can look like a U, a V, or a W. There's no consistent relationship to the uterine contractions. They occur abruptly with quick deceleration, and they're transient and correctable. They're associated with cord compression, and they're typically classified as either 2 or 3, depending on the accompanying change in the baseline. I know that this is a lot of information, and we are moving fast. Know that this lecture is recorded so that you can listen to it at your leisure from home, okay? I don't want anybody to panic. Interventions for variable decelerations include the same as the other interventions. So we're going to change maternal lateral position. We're going to provide oxygen 8 to 10 liters via mask. We're going to increase her IV fluids and provide an IV bolus. We're going to notify the MD, and we're going to prepare for a C-section. Late decelerations are apparent, usually symmetrical. They're transient decreases in the fetal heart rate that occur after the peak of the contraction. So these are can be visualized on page 462 in the bottom left corner, figure 14.8, if you're wanting to visualize the difference in these decelerations and how they correlate to the contraction pattern. The fetal heart rate does not return to baseline until well after the contraction has ended. The delayed timing occurs with the nadir of the uterine contraction. The causes are associated with uteroplacental insufficiency, which occurs when the placental blood flow is decreased and causes fetal hypoxia. It can be caused by maternal hypotension, gestational hypertension, placental aging due to diabetes or postdates. Again, postdates is after her due date. Hyperstimulation with oxytocin. So now we've created too many contractions. Remember the rubber band around the finger. Now we're not perfusing the placenta or the baby. Maternal smoking, anemia, or cardiac disease. It implies some degree of fetal hypoxia. Recurrent or intermittent late decelerations are always category 2, intermediate, and category 3, abnormal, regardless of depth. So the depth of the late deceleration doesn't change the fact that we're concerned. Acute episodes with moderate variability are most likely correctable. However, chronic episodes with loss of variability is less likely to be correctable, and we're going to move to an operative birth at that point. Interventions, we need to prepare for an immediate delivery if warranted. If the chronic episodes are consistent, like we were just talking about, and variability does not improve with our interventions, like we've discussed, then we're going to continue to move forward with a C-section. Prolonged decelerations are abrupt. The fetal heart rate declines of at least 15 beats per minute that last longer than 2 minutes, but less than 10. Usually drops to less than 90 beats per minute. The causes can include prolonged cord compression, abruptio placenta, which is a placental abruption. Again, that placenta is moving away from that uterine wall prematurely. The cord prolapse that we discussed before, where the cord comes before the baby. Supine maternal position, so she's compressing that inferior vena cava. A vaginal exam can cause this. Maternal seizures, regional anesthesia, and uterine rupture. So I am going to take a moment, and I will continue to lecture past our time. If you have to go, please know that it will be recorded and available to you. I just want to make sure that we get all the information. But I do want to share this with you because it is a lot of information, and I don't want you to feel completely overwhelmed. So I want to share with you a better way to maybe remember. Oh, shoot. Hold on. 1 second. I have to change it. Maybe.
New share.
It's not working. Hold on. Oh, here we go. Hold, please. Technical difficulties at the wrong time is the problem. Okay, so I want to share this picture to help you remember the fetal heart rate baseline. Let's see if I can fix it here. So you should be able to see this now, correct?
No.
No, it's just the PowerPoint.
Okay. Now?
No.
Ugh. Now?
Yes.
Yes. Yay, got it.
I feel like a cell phone commercial. Can you hear me now?
Can you see it now?
So quick activity. I want you to write veal down the left-hand side of a scratch piece of paper and chop down the other side. So veal down one side, chop down the other. So you can either write it or take a picture if that's easier and faster for you. And again, this will be available to you in the recorded lectures. So I want to show you how the fetal decelerations, how you can quickly determine what might be causing that decel. So this is a trick that I was taught early in my practice. So V for variable is caused by cord compression. E, early, caused by head compression, so veal chop. A for acceleration is okay, so accelerations are reassuring. Late, or the L in veal, correlates to the P in chop, which is placental insufficiency. So if you're thinking about, well, the patient's having variables, what might be causing that, you can quickly think veal chop. The first letter correlates to the first letter. I'm looking at cord compression. How do I relieve that compression and move forward? I hope you find that helpful. I am going to continue to move on. So again, either take a picture with your cell phone or access the recording in the My Courses. Okay. Okay. Now let's see if I know how to move back to my lecture because.
Got it.
Uh-oh.
Got it.
Hold on. Slideshow from current slide. Woo! Did it.
Good.
Yeah.
So hopefully that makes it a little bit less complex. I know it's a lot of information. I know that we're moving fast. Take a big deep breath. We'll get through this, promise. All right, so pain during labor. So we talked about how it's a universal experience. All women are going to experience some level of uncomfortability or pain during their labor and birth response. It's unique to every woman based on various contributing physiologic, emotional, and social and cultural factors. So we have some subset of some cultures that are very stoic in their labors, and that cultural impact might not lend itself to showing us how uncomfortable she truly is. Physical causes of pain during labor include that cervical stretching. Again, those stretching receptors aren't blocked. Hypoxia of the uterine muscle due to the decrease in perfusion during contractions. Again, during that contraction, it cuts off perfusion to the muscles and the placenta and subsequently to the baby. The pain could be also caused by pressures on the urethra, the bladder, and the rectum, and distension of the muscles of the pelvic floor. So today, many women have many safe non-pharmacologic and pharmacologic choices for the management of pain during labor and birth. It can be used separately or in combination with one another. Pharmacologic approaches are directed at eliminating the physical sensation of labor pain. whereas non-pharmacologic approaches are largely directed at prevention of suffering. So that would be like your aromatherapy or your hydrotherapy or your non-pharmacologic interventions. Nurses are in an ideal position to provide childbearing women with balanced, clear, concise information about effective non-pharmacologic and pharmacological measures to relieve pain. Again, what are her wishes? On admission, we assess what is your plan for pain management. And if she tells me she doesn't want an epidural, I'm not going to continue to tout all the benefits of an epidural throughout her labor. I'm going to go ahead and say she doesn't want an epidural. So now I'm going to focus my attention to the non-pharmacologic toolkit that I have in order to help relieve some of that suffering that she's having. We talked a little bit about this. Non-pharmacological interventions include measures such as continuous labor support, hydrotherapy, hypnosis, ambulation, maternal position changes, acupuncture and acupressure, attention, focusing, and imagery, therapeutic touch and massage. Now, some women don't love to be touched, gotta be honest. So this isn't like a menu that all women are gonna find, okay, I'm gonna try hydrotherapy and then I'm gonna go ahead and go with a side of attention focusing and guided imagery. It's all in what what works for her. And she may try every single one of these and say, nope, not for me. I've had women say, can you please rub my back? And the minute I touch them, they say, don't touch me. And I'm like, okay, I won't touch you anymore. They have to try it to know whether or not they like it. Just because they liked massage prenatally does not mean they want to be touched in their labor. So we have to try different things. They can use breathing techniques and effleurage, which is the circular stroking motions made with the palm of the hand on the abdomen. You see a lot of this. I know that a lot of women naturally touch their abdomen. They're providing that relaxation. Many of these techniques and interventions are taught as part of childbirth classes, but it's very important to realize that a lot of these have to be practiced before they're put in place during labor. So things such as hypnosis, that's something that her and her partner need to practice leading up to labor. That's not something that she can come in and say, well, Cassandra, I've got a plan. I'm going to use hypnosis, heard wonderful things. Go ahead and hypnotize me. That's not how this works. So sidebar, I am a childbirth hypnosis instructor, and it is so much fun. But again, it's something that they practice week in and week out and day out with their partner leading up to delivery to make it effective. And even though they've practiced, it doesn't mean that they're necessarily going to be effective and find hypnosis helpful. It's all what happens in labor. Women cannot consciously direct the labor contraction, but they can control how they respond to them. That enhances their feelings of control. So basically they can't, they can only control their response. They can't control the actual contraction because we said those are involuntary. They can't say, nope, I'm going to take a break. No more contractions for me, please. They have to roll with the punches. We provide continuous labor support by offering a sustained presence to the laboring woman by providing emotional support, comfort measures, advocacy, information, advice. So I typically steer away from advice unless I would never say, well, I typically provide her the information and say, I feel, or in my practice, I've noticed, but you want to be careful with the word advice. Support for the partner and support person. Remember, the support person can include anyone she deems to be supportive to her during her labor. So other entities of support people could include her family, the midwife, the nurse, the doula, or anyone, like we said, close to her. Hydrotherapy. All right, so let's talk about this for a second. So hydrotherapy may or may not be available to her in the facility. It is absolutely something that she can do at home before her membranes rupture. So we want to make sure her membranes are intact before she gets in the tub at home. The reason why this is either offered or not offered in the hospital setting is based off of the ability to, one, clean the tub, and two, respond to emergencies that may happen in the tub. So hydrotherapy could also look like a shower. A shower, the water runs over her back and abdomen. It provides comfort to her. So I don't want you to get caught up on that hydrotherapy can only happen in a tub setting. We can allow them with telemetry to enter the shower and use hydrotherapy in a shower setting. It provides soothing stimulation to the nerves of the skin. It provides vasodilation. It reverses that sympathetic nervous system response. And then it reduces all those catecholamines. It's amazing. You would not believe the level of comfort the hydrotherapy provides. Contractions are usually less painful in warm water because the warmth and buoyancy of the water, if she's in the tub, have a relaxing effect. Ambulation and position changes. Again, I'm going to move quickly over this. We've talked about how we really want women to be moving, walking, swaying those hips, changing their positions every 30 minutes from those kneeling, standing, and lying down positions. We want those rhythmic movements so that she can continue to open that pelvis and bring that baby down. Acupuncture and acupressure, we want to help relieve any pain during labor by applying gentle pressure to, which involves stimulating the key trigger points, and applying a firm pressure to areas that might be bothering her. Sometimes it's the hips, sometimes it's the back. It depends on her and what she's reporting to you. Application of cold and heat have been very widely used, and women rave about how much comfort and distraction it provides. So for instance, if you apply a cold compress to the forehead, sometimes that moves their distraction to the coldness of the cloth. Attention, focusing, and imagery. So you want to refocus her direction using touch, massage, or stroke to provide that tactile stimuli. And then some auditory stimuli such as music, allowing her to hum or directing her to hum through her contractions. Sometimes this happens spontaneously. And then just providing that verbal encouragement. So just telling her softly while she's in the middle of a contraction and breathing, "You've got this, you're doing great, keep going, it's almost over," helps her too. Sometimes she'll tell you to shut up, and that's okay. Don't have hurt feelings like me. It's okay. She might tell you to shut up. It's okay. Effleurage or massage, again, that light stroking of the abdomen. She might not want to be touched. Breathing techniques. So it's important that she remains in control of her own breath and that we reduce the amount of guided breathing that we have typically provided. I will not say that everybody does this. That's not true. But if TV has been largely to blame for the perception that breathing or pushing and breathing coordination needs to be, I'm going to have you hold your breath, count to 10, or scream at you and count to 10 before you're allowed to breathe again. That just causes that fear, tension, pain cycle. It quickly gets them very overworked and exhausted. So we're going to have her breathe at her own natural intervals and allow her to use those breathing techniques to guide her through the contractions and use her own intuition. Again, giving her the confidence that she knows what she's doing and her body knows what she's doing. Okay, 2 more slides, guys. Hang in there. I know we're over time. I apologize. Like I said, a lot of information. So it's important to talk about the pharmacologic pain relief measures. Neuraxial analgesia and anesthesia is the administration of analgesics or opioids or anesthetics capable of producing a loss of sensation in an area of the body. It's either continuously or intermittently into the epidural or intrathecal space to relieve pain. So in the event of a spinal, it is provided and it will eventually wear off. I'm sorry. In the event of an epidural, I'm sorry, I lie. It is produced into that intrathecal space, and it is a constant drip of that epidural anesthesia into that intrathecal space to provide that analgesic effect to the to the abdomen and below. Neuraxial analgesia does not interfere with the progress or the outcome of labor. This technique allows a woman to be an active participant in her labor. Systemic analgesia involves the use of one or more drugs administered either orally, intramuscularly, or intravenously. It is distributed throughout the body. Depending on the route of administration, the therapeutic effect of pain relief can occur within minutes and last for several hours. Complications are associated with the use of this class of drugs include respiratory depression. So we need to be careful when we're administering these. Opioids given close to the time of birth can cause CNS depression in the newborn, necessitating the administration of Narcan to reverse the depressant effects of the opioids. So opioids such as morphine, Stadol, or Nubain, antiemetics such as Vistaril, Phenergan, or Compazine, or benzodiazepines such as Valium or Versed are common meds used for systemic analgesia. All meds given during labor end up crossing the placenta and can have that depressant effect on the fetus. So it's important that women receive the least amount, remember, go start low, go slow. So the least amount of systemic medication that relieves her discomfort so that it does not cause harm to the fetus. So if she's 7 centimeters, I'm not going to go ahead and give her medication via IV that could depress my baby on delivery. I'm going to go ahead and figure out what else can I provide that's not going to cause that respiratory depression or CNS depression in the newborn. So it is very important that we know exactly where our patient is in the labor process and what pharmacologic pain management techniques we have in our back pocket. So inhaled analgesics, so that refers to our nitrous oxide or laughing gas. So think about the dentist, you might remember or have had experience with a mask they place over your mouth and nose and provide that 50-50 mix of nitrous oxide gas and oxygen, and it gives you that like tingling effect. Like it doesn't take away the pain necessarily, but it takes away the care that the pain is occurring. So the woman is self administering. So we instruct her, she raises the mask to her face, takes some deep breaths. She cannot provide too much because once she's relaxed, her hand will fall away from her face with the mask and she'll begin breathing air and then it'll start to wear off. So some people love it, some people hate it. Again, you have to try it in labor or not have to, but they won't know whether or not they like it or hate it until it's trialed in labor and they're able to make that determination. Some people say it works great. Some people says it makes them feel funny, like they don't like feeling, it's almost like that loss of control again. Regional analgesia, anesthesia, is pain relief without loss of consciousness. So it's a use of local anesthetic agents with or without opioids. It brings pain relief or numbness through the drug's effects on the spinal cord and nerve roots. So you have your epidural block, you have a combined spinal epidural, local infiltration, a pudendal block, and your intrathecal or spinal, which is your analgesia anesthesia. If we're moving to a stat section, we don't have time for an epidural or a spinal, or mom has some spinal anomalies that prohibit her from having a spinal set in place, we will then move to general anesthesia, which is typically reserved for those emergency births, but they can be started quickly and they cause rapid loss of consciousness. So general anesthesia is not something that we typically see a whole lot of, again, unless we're in that emergent setting or mom has something anatomically prohibiting her from having a spinal placed. And that is usually determined through a assessment with the anesthesiologist on admission. If it's a anatomical issue such as scoliosis, maybe she has some rods placed that we need to be aware of. Or a spina bifida, I'm sorry, that too would also prohibit her from having a spinal. So, last slide, guys. Thank you so much for hanging in there. So childbirth is a physiologic process that is fundamental to all human existence. It's one of the most significant cultural, psychological, spiritual, and behavioral events in a woman's life. We talked about how important it is for women and how it imprints on them. The nurse's role in childbirth is to ensure a safe environment for the mother and her newborn. Nurses begin evaluating the mother and fetus during admission procedure. That happens from the minute I lay eyes on her. I begin evaluating. I look to see, does she look like she's in comfort? Do I see any fluid leaking? How about any vaginal bleeding? I'm asking her questions. I ask her questions from the minute I pick her up in the lobby all the way until I get her in the bed. I've got more than half of my visual assessment complete by the time I get her situated and onto the monitors. We provide anticipatory guidance and explain each procedure, such as fetal monitoring, intravenous therapy that we might provide, and the medications given and those expected reactions, so that she's not shocked when she asks to try the nitrous and then she says, "You didn't tell me that I was going to be all tingly. I don't like that." At least she will have heard it. Our role is to know how and when to evaluate a woman during the various stages of labor. It's essential for all labor and birth nurses to ensure a positive maternal experience and a healthy newborn. Very important. Healthy newborn, healthy mom. Those are our goals. Major focus of care for the woman during labor and birth is assisting her with maintaining control over her pain and emotions. And her actions, have to tell you, been grabbed, hit, punched many times. So it's important for us to refocus her and let her know that she can do this. She's in control, and that the loss of control feeds into that fear, tension, pain cycle and actually makes things a little bit more difficult for her. So we want her to be an active participant in her labor too. So we don't want to shut her down completely. We just want to re-guide her. In the first stage, the care is dependent on how far the patient is when she arrives in labor. The nurse will determine assessment parameters of maternal fetal status and plan the care accordingly. The nurse will provide high-touch, low-tech supportive nursing care during the first stage of labor when admitting the patient and orienting her to that labor suite. So we're not just throwing everything at her and overwhelming her either. We're showing her that we're here, we're guiding, we're comforting. The nurse is usually the primary gatekeeper of the observations, the interventions, the treatments, and often the management of labor in the inpatient setting. We work very autonomously. That's not to say that we work aside from the doctor. We are very much in charge of that labor process for that mom and communicating back and forth to the physician. This is probably one of the higher areas of physician communication and interaction that you'll have in the hospital setting. We communicate very frequently and thoroughly and accurately to our physicians, and oftentimes they're on the units with us. Nursing care in the second stage of labor requires a nurse to have a comprehensive understanding of the physiology. We must be aware of the latest evidence and research and apply it to practice. Again, knowing that those peanut balls decrease our C-section prevalence is important, and then putting it into practice. So it's great to know it, but what are you going to do with that information? You've got to start implementing it into your practice, and then seeing how it affects your patient's labor outcomes. Evidence supports the practice of delayed pushing. So delaying the pushing to when the mom feels like she needs to push. She's going to tell me, I feel the pressure and the urge, and then we're going to go ahead and let her push. We're not going to say, let's push now just because you're 10 centimeters, because that we know that doesn't help mom have a quicker delivery or pushing phase. Spontaneous, non-directed pushing was what we were just talking about. And the maternal choice in positions. If she tells you that she's uncomfortable in a certain position, well, then let's try a different position that might make her a little bit more comfortable, because it's going to bring down that anxiety. It's important to continue assessments during the second stage of labor, which involves identifying the signs typical of the second stage of labor. So we need to identify those to know that we're in the second stage. Nursing interventions during this stage focus on motivating the woman. Again, we become her biggest cheerleader. assisting with positioning and oftentimes repositioning and repositioning again, encouraging her to put all of her efforts to pushing the newborn into the world. The third stage is marked by strong uterine contractions as they continue to, at regular intervals, under the continuing influence of oxytocin, either her own oxytocin or the oxytocin we're providing her to help augment her labor. The third stage is complete when the placenta is delivered. Nursing care during this stage primarily focuses on immediate newborn care, assessment and observing for signs of placental separation, again, making sure that the placenta is coming away from that uterine wall, and being available to assist with the delivery of that placenta and providing the documentation in the EMR. Specific assessments during the third stage of labor include monitoring for placental separation, examining the placenta and fetal membranes for intactness. Again, we don't want to leave any pieces of the placenta behind as it might increase our risk for postpartum hemorrhage and or infection, assessing for any perineal trauma. And our interventions include administering oxytocin after the placental expulsion. This is to increase the contractility and decrease the bleeding. We make women comfortable after delivery, and we help promote bonding. The last stage, the fourth stage, begins after the placenta is expelled and lasts up to 4 hours after birth. It is the time known as recovery. So again, recovery is very much facility and or organizational driven. It can, like we said, last up to 4 hours after delivery. Assessment centers on the woman's vital signs, status of the uterine fundus, so we check that every 15 minutes, perineal area, comfort level, the lochia amount. Lochia refers to the amount of bleeding that's present. Again, if you waited for me to tell you what lochia was, please write it down. And then the bladder status. Assessing the fundal height, position, and firmness every 15 minutes during the first hour following birth is essential to make sure that we're aware of how much bleeding she has and the status of that fundus to make sure that it's firm and not boggy. Again, boggy is kind of that mushiness to the uterus that is not conducive to the decreased amount of bleeding. Interventions during the fourth stage include applying ice to the perineum to promote comfort and reduce any swelling, assist with hygiene and perinatal care, and monitoring for return of sensation and the ability to void. Bladder distension is extremely important to continue to monitor. As the bladder becomes distended, it displaces the uterus, which decreases the contractility and then increases the bleeding. So we want to keep that bladder nice and empty in order for that uterus to continue to contract down. And that, my friends, is the conclusion of your lecture. Thank you so much for bearing with me, those that stayed. Those that go or had to go, I totally understand. And we can open up for some brief questions like we promised at the beginning of the lecture. Let me go ahead and see if I can change stop sharing. How do I do that? Stop share. Okay. Are there any questions? Anybody wishing to be
I will say thank you. And I appreciate you telling everybody thank you for staying on for later. What I also would like to tell everybody is remember, typically on the Wednesday and Thursday for us, we have a 2-hour skills lab.
Correct. Yeah.
That we are not having while we're doing this online stuff. But so typically, even though she went a little bit longer here at 11, on a typical in-class setting, we could continue that lecture in the afternoon. So you still really are assigned to be in class, right, except for lunchtime, until 2 o'clock. So even though she is apologizing for running late, and I admire her for that, you still have class time until 2 o'clock.
Thank you so much. I appreciate that. Sam's asking, so can we plan that in advance so we can plan ahead? I think Dr. Brown's message was clear that, you know, if we do end up running over, the expectation on normal Wednesdays is that that we're here until 2. So I think that I can only speak for myself. I don't know, Mrs. Concepcion, since you've lectured already on Wednesdays, the Zoom brings a different element to it, and it's a lot harder for me to share or help explain things in a timely fashion. It takes a little bit more time to do so. So it does end up running over. I actually think that we're about the same time frame as we were when Mrs. Concepcion was lecturing last week. So I'm sorry?
I think we are, yeah.
So I think maybe we should plan to err on the side of caution and plan to be here. And then if we get out early, it's a bonus.
Right. I would think so too. I think it would be easier that way for those that need to make, let's say, adjustments or to make plans, ahead of time. I think it would be easier for everyone in that sense, just because of, instead of trying to rush through the information to try to give you an adequate, lecture. I think if everyone knows that, we might go, let's say, even if everyone kind of like schedules it till 12, then I think we all at least know that we're including the information, giving you enough time to kind of absorb the information, allowing for questions, and yet everyone's kind of already planned their day that we might be here till 12 without having to kind of feel rushed.
I agree. And I think that it allows us to really dive into those questions too, which will help you with your studying. I have Ivana says, since we don't really have much time, how much in depth you need us to go with this information, or the information worth for a week of studying? So I think she's saying that's a lot of information.
Use your PowerPoint, guys, as your guide for the important parts that you need to focus on. So like, if you remember, this lecture talked about a lot of like the fetal assessment and how we would note fetal assessment. So like knowing what a category 1 fetal strip is, knowing what a category 2 or category 3, knowing what a variable is, acceleration, a decel, a late decel. That's going to be important. It was covered in your PowerPoint. It's covered really well in this chapter, and that's important for you guys to know. When Professor Griffin put in veal chop, that's a nice, easy way of remembering what each of those parts mean. That's important for you guys to know, because that talks about the nurse's actions, the nurse's interventions on what we do when we have a situation with this fetal assessment. So those things that have to do with assessments and interventions that the nurses do, that's as far as we need you to really focus on. And that's what this lecture kind of tried to do, is really what the nurse's role is and taking care of patient in labor. So that, as much as, a lot of the physiology stuff, a lot of the pathophys stuff is not going to be as important, but as the nursing intervention stuff is going to be.
Any questions?
And like I said, just keep making sure I know a lot of people's questions are more like how the chapters are long and how in detail, but use these PowerPoints. They're kind of cut up to give you the short and sweets of what you need to know from the chapter. Use the PowerPoints to help you.
And please,
and that's fine. Yes. So you can email us questions whenever you need to get clarification.
Right. Absolutely.
And the recorded lecture will be in my courses, correct?
Yes, it's recording actually these questions as well. So when we're done with the meeting and we end the meeting, then as soon as I get it uploaded onto my computer, I will put it under the PowerPoints for today's lecture.
So Asia's asking, for time purposes, do you recommend using the ATI book or textbook? Because I don't think there's time for both.
Your ATI book, remember, it's like for those of us who are kind of older and remember Cliff Notes, is like the Cliff Note version of an OB book. Okay, so if you can get the information and understand the concepts with your ATI book, then great, use your ATI book. But if you need a little bit more of explanation, if the ATI book bullet points aren't just enough for you to understand the concept, then go back to that section in your Ritchie book to reread that section in your Ritchie book to give you the content or the concept that you need more explaining on. So you can use both of them, but you don't have to read both of them like if they were chapters. Use your ATI book to give you those bullet points that you need to focus